Hello, this is Colleen Morley for CMSA Chicago, and welcome to another episode of CMSA Chicago Issue Spotlight, our informational video series discussing the various issues in case management. Today's video puts the spotlight on transitions of care and is discussed by Cheri Lattimer, BSN RN. Cheri Lattimer is the Executive Director of the National Transitions of Care Coalition, or NTOC, and is President CEO of Integrity Advocacy and Management. Her leadership in quality management, case management, care coordination, and transitions of care is known on the national and international landscape. Her work has been featured in several publications, including the Healthcare Executive, Dorland's Case in Point, Professional Case Management, Social Work Today, and Seniority. She's affiliated with various professional organizations and maintains active roles on several national boards and committees, including URAC's Redefined Health, CMS Caregiver Work Group, Achieve, AVQ AURP CME committee, there's a lot of letters there, and the American Nurses Association. Cheri has a Bachelor of Science in Nursing from the University of Phoenix and graduate studies in organizational redesign on human resources. Welcome, Cheri, and thank you so much for taking the time to talk with us today.
Well, thank you, Colleen. It's my privilege.
Well, Cheri, can you tell us a little bit about yourself and how you got involved in transitions of care?
Absolutely. I am, as you shared with the audience, a nurse by training, and I've been privileged throughout my career to work in many areas of my field as a nurse. But I have spent the last 25 years working as a nurse leader in utilization management and case management, transitions of care, and improving the quality of care for patients. In 2005, when I was serving as the executive director for National CMSA, Santa Fe Venice asked the question, is transitions of care an issue for case managers? And that was a pretty easy question for me to answer. And that initial contact in 2005 really started and launched the work of the National Transitions of Care Coalition. CMSA was a founding member and was really staffed the operations of the organization for a significant amount of years. And it's through those discussions that we've had with case managers in the field and the things that I've observed in my own career that we really began to work as a interdisciplinary team. And I think that's important because transitions is not about one discipline. It is about the full care team, really talking about what those issues are and what we needed to do. I've always been convinced that we could do better. And all the work that we've done since 2006, when we were officially formed, has continued to focus on what's the next thing, what is it that we can do better. The role for patient advocacy and the need is more evident today than ever with the COVID-19 and the issues of transitions and care coordination through this pandemic. That role will consistently be one that we'll be looking at.
I agree. I remember when I first started out as a nurse, those many years ago, we really didn't have case managers or social workers on the nursing units to help with those transitions of care, but rather it was, get the patient to a skilled nursing facility, and it was up to the floor nurse to make that happen. So can you give me a little bit of background on how formal transitions of care programs actually came about?
Absolutely. I think it always behooves us to really talk about what is a transition of care, which is a change for that patient and family caregiver on any level of service or ever any interaction with the patient. We think about transitions and we go, okay, well, that's a transition from the hospital to home or the hospital to long-term care. But in reality, when the primary care sends the patient to the specialist, that is a transition of care. When the specialist says, we need physical therapy and we're going to send you to rehab for a few weeks, that is a transition of care. Wherever we see this change in provider and level of care and service in the intervention, those become transitions of care. And in that process, there are so many gaps and barriers, Colleen, that we have defined over the years, not only as NTalk, but leaders in the field, Eric Coleman and Dr. Mary Naylor, as they've worked on these various models. You know, some of the things that we've identified that are huge gaps and barriers are the medication management, the reconciliation and the coordination of that, whether at the hospital or just between the multiple providers that a patient with comorbid illnesses is going to see. Whether we're talking about the fact that that lack of communication to the patient and the family caregiver can often affect how well the patient is going to work with the team. The lack of communication from provider to provider. I don't think I need to really go into depth about that. We as nurses, social workers, case managers have seen this so many, many times. The lack of a timely follow-up of information or tests, or a discharge, or even a transfer from an emergency room back to home. And we say, okay, we're going to order some home care. We're going to get some DME equipment in, and that referral doesn't come, and the patient and family are waiting. So that communication piece. And then the lack of really the transfer and accountability among providers for this actual role has really identified that. So patients who have multiple comorbidities, see multiple providers, take multiple medications, become even higher at risk for these gaps and barriers that we've just talked about. And the impact of these failures can be catastrophic in many, many ways.
I agree with you 100% there. We see the impact in readmissions. We see the impact in morbidity and mortality. What are your top 3 things that you think really puts a major risk factor on transitions of care? And who really does it impact, and what could be some of those outcomes that you've seen throughout your career?
Well, I think when we talk about the impact of these gaps and these barriers, probably one of the highest points that we talk about is this medication reconciliation and management when a patient moves from one level of care to the next. As I said, the increased risk when there are multiple comorbidities, multiple providers, multiple medications, and the patient goes into the hospital and there really is no knowledge of the multiple providers. The patient is now in the hospital and we're going to get new medications, and that reconciliation, that often causes a medication error. It can be anything from a medication overdose to we now have them on 3 and 4 statins rather than just the one statin that they should have been on. And so we get a hospital readmission. When we see these things happening, Colleen, we see not only the lack of the quality of really that positive coordination that we should have had, impactful, we see costs that could have been avoided had we really looked at this in a, what do I want to say, a more thorough investigation rather than just looking at a particular symptom and a medication for that particular symptom. I think the other thing that I always like to talk about too is we talk about the financial impact because it can be significant, but there are large emotional impacts that happen to the patient and the family caregiver. It is not unusual for us to hear today where patients and family caregivers are having a hard time trusting our healthcare system, trusting the providers, not knowing who to talk to. It, from their perspective, we should be talking to each other. Why aren't we talking to each other? Why am I having to tell the same story over and over again, give you the same information? I just gave that to so-and-so. So those things really begin to weigh also, and that impact can actually be more disastrous sometimes than what we're seeing on even a hospital readmission, because we tend to see patients and their family caregivers pull away from the system rather than become more engaging in the system. So I would say those are some of the impacts. The other impact that we're seeing, and we're seeing it with COVID too, is we ask more and more of the caregiver. in working with the patient and following through on procedures. And let's just take COVID-19 because I know that's in everyone's mind. So today, that caregiver needs to understand infection control, needs to understand if my patient is being isolated or my loved one's being isolated, what does that mean? What does that mean for other people in my family? Are there procedures that I will have to do that I haven't been trained to do? So the impact there becomes even more vital, and I think becomes a role that we can talk about, and as we talk about how to address this, that the case manager, whether a social worker or a nurse, is really attuned to be able to take on and be the advocate for that patient and family caregiver.
Agreed 100% there as well. I see it every day as a director of inpatient case management here. Um, we're seeing that we're sending some of our patients home sicker and expecting the families to step up and do a lot more than they're used to doing. So there's a lot of patient and family teaching that we have to do. So how can we better prepare our patients and ourselves for these transitions of care? What are some suggestions that you have?
I'm going to start with one of the statements I made when we started this discussion. I don't want anyone disciplined to ever think that they are totally responsible for a transitions of care. And let's take at the hospital level. I believe hospitals really need to talk about how this is an interdisciplinary care team function and what are the roles and functions of the people on that particular team. If we only can see what we need to do between the four walls that we're working and that we do not have a responsibility beyond those four walls, we'll continue to have these gaps and barriers. From the hospital level, what are my resources beyond my hospital? Who can I connect with at that point of transition, whether going home into a long-term care, a post-acute facility, going home, going to rehab? How do I connect? How do I share that information? And what is it that I need to do? You know, NTALK developed in its early ages, it developed what it called the 7 elements of a bundle that we put together. And they have become kind of key measures that not only do we talk about, but today are being measured by NQF and CMS and our various organizations. So let me run through that real quick, because I think if you can keep those in the back of your mind and then talk about how is my role, what do I need to do, we've actually can make a difference. Medication management and coordination. How does the pharmacist and the case manager actually work together at the hospital level to share that same information and to support the patient and the family caregiver? We're seeing today that there are hospitals and systems out there where they're actually placing a pharmacist in the case management department, Colleen, because this has become so important. How do we better engage the patient and the family caregiver in education, support, and making them part of the family and part of the care team? I think we do a disservice when we don't understand that the patient, the family caregiver are the only common denominator in these transitions. We as hospital teams aren't moving to the long-term care. Our long-term care staff is not moving to home. So how do we engage that patient and family caregiver? Good transition planning, and that includes assessing the social influencers of health. What's happening beyond the walls to this patient and family caregiver that I need to understand? Transportation, safe housing. Is there food insecurity? Do I have if I'm told that I have a cardiac problem and I need to get out and walk every day, do I have sidewalks to walk on? Or am I living in an area where there are no sidewalks and it's not safe for me to walk? Good information transfer. Let's do this in a timely manner. If you're leaving the hospital, make sure the patient, family caregiver have those discharge transition instructions and they go to that next level of care so there can be a discussion. If there's follow-up care, referrals for DME, home health, follow up from a test that we didn't have, who's going to take responsibility for that? And definitely the next two, shared accountability across providers and full provider engagement. When we talk about providers, talk about that whole clinical team that needs to be able to work together. Those key elements are working in every model that is being successful. I'm going to leave you with this last statement because I believe this with my whole heart. Professional case managers, whether nurses or social workers, have a significant role in providing that patient advocacy as we talk about transitions of care, that need to support the patient and the family caregiver, and in assisting the clinical interdisciplinary care team to understand what are those patient and family caregivers' preferences, special needs, and just look beyond the symptoms to these other things that can influence a poor transition. Because without that communication, we'll continue to see those gaps and barriers.
Excellent, excellent way to sum up the whole transitions of care problem. It's really talking about the patient and the family and putting them at the center of care and making sure that everything gets taken care of for them to make sure that they'll be successful on the other end. Thank you so much for joining me today, Cheri. It's been an honor and a pleasure chatting with you about transitions of care.
Anytime. So all take care, and remember, communicate, communicate, communicate.
Thank you.